This week on the BackTable podcast.
Let's say someone comes in with T1 ureteral disease and T1 disease in the bladder. So you kind of feel like they need an FU, but they also need intravesical therapy. How are you sequencing that?
I generally get the bladder clear first and then attack the upper tract disease. Very similar to, I think, what Sarah mentioned earlier. Is a patient that is distal ureteral T1 disease and they want a cystectomy, then I might take care of it all at the same time. Just do distal ureterectomy, cystectomy. But if they desire bladder and kidney preservation, then yeah, I'd get the bladder clear and then reassess, and then hopefully have ablated most of the upper tract tumor to the extent possible, and then attack the upper tract disease. I don't know if there's a right way of doing this. Obviously, the ureteral disease is more significant in terms of the threat to the patient. I mean, the ureter is just so much thinner, smaller. You know, it just seems like metastatic disease is just so much easier through the ureter.
Welcome back to BackTable. I'm Vignesh Packiam. I'm excited to have a great tumor board session today with two amazing urologists, Dr. Mark Tyson and Dr. Sarah Psutka. So let's step back from the specific treatments and kind of go more into the investigation. Let's say a patient has failed numerous treatments, let's say 3-4 lines of therapy. They're still very motivated to keep their bladder. They come and see you for the first time. How aggressively are you looking for cancer in the sanctuary sites, upper tracts, prostatic urethra?
Yeah, so let's start with restaging scans for most of those patients. Probably hasn't been updated in 6 to 12 months anyway. So CT urogram, and like Sarah said, especially for invasive disease, CT of the chest. That would be the extent, that in cytology. I'm not putting up scopes, looking up any place that doesn't have an obvious pathology on CT. Unless I wasn't able to track down a positive cytology, I don't routinely do selective cytologies. I'd be interested in your opinions on this, but it's a little bit like you're putting the catheter through the bladder into the upper tract, and then there's like holes in the catheter. I mean, it's like how confident are we that we've sampled the upper tract and there's suspicious cytology or positive cytology on one side? How confident are we that it's actually from the upper tract?
That's always the question.
I mean, I don't know. So I generally don't do selective cytologies. I will if I'm chasing a positive cytology and a bladder mapping was negative. But if this patient has CIS and they're coming to see me, they've been through 3 or 4 lines of therapy, I get a CT urogram and cytology. CT urogram was negative. Cytology was, I wouldn't chase the upper tracts, but I probably would remap the bladder with a blue light cystoscopy and prostatic urethral biopsies.
Would you random bladder biopsies and prostatic urethra even if it looks negative?
I would. Yeah. So, this is somebody that's coming to see you. They have a history of CIS. Who knows how much of that CIS they've cleared. They have a long-standing history. So if we're trying to get this patient clear and save them from losing their bladder, then I think that would be a good first step for most patients. Now, if they're older and they're on anticoagulation, they've got an occluded LAD stent, that's, maybe not. Maybe I would just put them on maybe a flex blue light in the office without biopsies, but generally I would remap them.
You're probably one of the few in the country with flex blue light, so that's a unique situation. Let's say you didn't. Would that patient be going to the operating room?
Yeah, generally, I think so. I think it does 2 things. One, it gets their bladder clear, and there's a question about whether that's beneficial or not. But 2, it also gives you kind of the most up-to-date information on what their disease is, and that'll help drive decision-making, I think.
So let's say, one of these prostatic urethral biopsies comes back positive for CIS. And, this patient was managed by you. They failed BCG or these treatments failed them. BCG, gemdosi. Patient is very motivated to keep their bladder and prostate. What is your next step?
So I think prostatic urethral CIS is a particularly bad actor. We know from retrospective data that patients that have prostatic urethral tumors in the setting of non-muscle invasive disease are at some of the highest risks of progressing to muscle invasive disease. And I do worry about these patients being in that 6 to 9% that have the higher risk of nodal disease locally. So I think Mark's point about the cross-sectional imaging at this point is actually really important. But let's say that we have prostatic urethral CIS. So I do the thing where you go and you resect out that prostate, basically give them a decent TURP. And then at that point, think about intravesical therapy. I think this is a tough patient population because you don't know that prostatic urethra, you might have cleared the bladder. The bladder may be disease-free, but you don't know that the prostatic urethra has actually seen any of those intravesical agents. And it probably hasn't, especially if they're someone who's older and has a big prostate. I literally have a patient just like this in my practice right now, and we're going to the OR, so we're going to do a TURP, and then we're actually going to re-induce with some intravesical therapy because of lack of other options, and this is something that we've arrived at after shared decision making. But I think that that's a tricky part because I'm not sure that that's actually BCG unresponsive disease. It's very high likelihood it actually never saw the drug to begin with.
That's a really good point. I learned this from Mike O'Donnell when I was at Iowa, but he would do a TURP, but he'd call it a double donut TURP. So he would do the mucosa, send that, and then he'd do a deeper layer and send that also, just to really figure out how deep the CIS
That's a great
is
way
really
to do
going.
it. I just do a proper TURP it. But I think it's really important to make sure. I do think I see a lot of patients who come to see me who have been staged, who have never had their prostatic urethra sampled, and I just think that that's where cancer tends to hide. So I'm a pretty big proponent, actually, for anybody with high-grade T1. First, like going back to our first analysis, our first evaluation, I always do the swipes at 5 and 7 just to make sure.
Okay. Well, let's say our treatment works now. They got additional BCG. And now patients seeing you, we're going to make this more complex. Positive cytology.
It's like clinic on Monday, right?
Really getting in the weeds. Bladder is negative on blue light. Bladder biopsies are negative. So now you are starting to hunt down the upper tracts. And you have an isolated positive cytology from one upper tract. Imaging is negative. You even scope it and it's negative. How do you deal with that positive cytology?
We've scoped both upper tracts.
Correct.
Negative.
The scopes are negative, but you have one isolated upper tract cytology that's positive.
Oh, one isolated upper tract is positive. For this patient, I'd continue them on maintenance BCG and do another CT urogram in 3 to 6 months. It's a 75-year-old patient who's probably already got some baseline comorbidities, and we have a positive cytology from a kidney. Even if that's an upper tract tumor, that's just subclinical. It's going to be a few years before it manifests itself, and probably even another year or two after that until it becomes metastatic. So I think in this particular case, and there's some assumptions that are underlying that statement there, but I think for the average patient, we could just continue maintenance BCG and surveil the upper tracts.
Yeah, I think I've heard a lot of conflicting thoughts on this. The other argument is this is at an early point and maybe we can nip it at the bud if we aggressively put some topical therapy into that upper tract. But that's, it's kind of a niche
But
viewpoint.
topical therapy for the upper tract for high-grade disease, we just don't have great options. I mean, I think that we don't have excellent treatment options, and I would hesitate. I think when I have patients who have, so I don't know how you guys feel about the Pembro data. We don't use Pembro much for BCG-unresponsive disease, largely because of the sort of lack of durability of the response, the lack of the robustness of the response, but also the side effect profile. But the people who I do think about it in are those people who have concomitant upper tract high-risk disease, especially carcinoma in situ and lower tract disease. But I'm not going to give anyone treatment for just a cytology.
Yeah.
I need to be able to prove that before we put them at the risk of the side effects that there's actually cancer there.
Yeah.
Because to Mark's point, I mean, it could just be a contaminant from the bladder.
Yeah, possible. We had some data from Iowa showing that, giving BCG or gemdosi to the upper tract could clear that positive cytology at a rate about 90% at 1 year.
Were you giving it through a nephrostomy?
Through a nephrostomy.
Yeah.
So it's a tough treatment. It just depends, philosophically, are we trusting that cytology or not?
And I also wonder if that's complete response rate is subject somewhat to the sensitivity of cytology.
Sure.
Mm-hmm.
I have not had great experience with percutaneous administration of intracavitary therapy, gemdosi and BCG. Both most of the time have not succeeded in patients who have visible disease. But I've tried it and I've used it and I'm still going to continue using it just because there's not a lot of options. So it's just not a lot of good options. So for this patient, I think surveillance would be very reasonable. If they were 50, maybe it'd be a little bit more aggressive. But at 74, I think I would just observe.
Okay. Well, let's say the positive cytology kind of goes away, upper tract is okay, but now there's recurrent CIS in the bladder. Patients failed multiple lines of treatment. They're ready for cystectomy.
Mm-hmm.
Are there special considerations for cystectomy in this setting that are different than your typical, post-neoadjuvant chemo, muscle-invasive bladder cancer cystectomy setting?
Good question. I think, so I would say I treat that cystectomy like I would treat a muscle-invasive cystectomy. One, because I think that these are the people who have been through multiple lines of therapy where I think there is a higher risk of potentially subclinical nodal disease just because this disease course has lasted so long, they have a little bit more risk. I definitely, if this is a patient who's getting a neobladder, I'm making sure that urethral margin is clean because I think these are the patients you worry about that CIS creeping into the urethra. They've had enough time for it to take hold, and I would worry about leaving disease behind. That's my personal preference. But I would still do a node dissection. I would still do, I try to do nerve sparing and functional preservation as much as I can, as long as I don't have any reason not to. Otherwise, I'm treating them it's pretty much the same way.
Are you typically doing frozen sections on your ureters, or would you do that more in this situation?
No, I do it for everybody, but that's, and not everybody, we have variable practice on that at UW, but I've always done frozen sections of the ureters.
Yeah. How about you?
I'm not. Yeah, I used to. I stopped. Probably would in this case. Routinely do it. But yeah, I think in this particular case, I would cut high on that, as you said, left ureter, and even do an on-table ureteroscopy. Times to do that. But yeah, send the frozen on that side in particular. But in general, just try to cut as far back on the ureters as I can, and then just send it for a permanent.
I totally agree. I think getting the ureteral margins and the ureteral margin is really important in these situations. One thing that I've done is, just in case that patient needs a urethrectomy down the road, it's rare, but it's possible, I like to tie off the urethra with some proline.
Nice.
That way it's easier to identify, because that's really frustrating when you're doing those cases and
absolutely
trying to figure out where to end. So
100%. That's a great idea.
Yeah.
So you mentioned the cysto trial. What are your thoughts about the data? I mean, I think a lot of us were a little bit surprised. And has that actually changed your practice when it comes to counseling these patients on their journey?
The cysto investigators, John and Angie and Erica and the whole team, deserve to be congratulated, because it's big, government funded trial. A lot of centers participated. It's a group effort, and data are very high quality. I think my understanding of the data is that I think physical function, might be the primary endpoint. And that showed that cystectomy wasn't as awful as we thought it was. But these are ultimately, at the end of the day, these are patients selecting their treatments. So I think I would summarize the data as such: in patients who select cystectomy, the decrement in the quality of life is not as severe as we thought it was. I genuinely don't know how that compares to bladder sparing therapies, because that's a different group of people that have selected their therapies. But the way I counsel patients now is that from that data, we know that the cystectomy quality of life is pretty good, actually, and in some ways maybe even better than what patients were previously expecting. How that relates relative to bladder sparing therapies, I think, is still an open question, but it appears to compare favorably.
My kind of aerial viewpoint of that is, I'd say 20 years ago, a lot of people were being very aggressive about upfront cystectomy, maybe even immediately for T1 disease or immediately after BCG failure. Now we've had more and more effective bladder sparing therapies, and I think a lot of us, myself included, got a little tunnel visioned into saving the bladders for as long as possible, because that's what a lot of patients said that they prioritized. But now I think we have to look back and look at the big picture again, and cystectomy probably has a bigger role than we thought 5 years ago.
I think and a big part of this, though, comes down to the counseling. And I think expectation setting. And one of the challenges, this is something we've been engaged in. We're running a prospective observational cohort study we call the Bounce Back study, which is all about understanding recovery trajectories, because we can look at somebody's path and we can predict risk of recurrence. We can predict risk of death from cancer pretty well. But we can't say at this stage, this is when you can go grocery shopping again. This is when you can go visit my patients can go visit their kids in Arizona, And so understanding that and giving patients sort of a clear view on the trade-offs, short-term, intermediate term, and long-term, I think is really important. I think the cysto data gives us some pretty good understanding of where things land a year later. But I do think that year can be pretty rocky for some patients, and not all people recover within 6 to 12 weeks. I think actually the vast majority of especially our older patients, really don't. And they start to feel kind of like themselves again if they get back to that point 9 to 12 months later in some cases, especially if they're pretty frail or pretty vulnerable at baseline. So I think that giving people an understanding, because what's hard for patients is when their experience doesn't map with their expectations. So if you tell patients, like, this is what you can expect. We do the cystectomy. This is kind of what the perioperative period is going to look like. This is what your recovery is going to look like. This is what things are going to look like about a year later. I think that can help actually improve quality of life, because that's a big question for a lot of folks, is sort of what are the trade-offs going to be? But ultimately, I think the cysto data is really important, because there are patients, and I see some of my older patients too, who say, I don't actually want to be in your office getting a scope in my bladder every 3 months, and I don't, or their baseline bladder symptoms are just so bad. I think this gives us some support to say life after cystectomy can be excellent as well. It just takes time but I think honestly going through what the expectations look like and saying it's not going to be necessarily really for anybody an easy ride is super important.
I think one of the reasons why Cysto is so successful is because they used these validated PRO metrics. Are those metrics being used in your practice when you're managing patients with NMIBC or only for clinical trials?
Yeah, I think a lot, like using like the EORTC, NMIBC 24 and things like that, that I'm using only in the context of clinical trial work. I use a self-report geriatric outcome assessment that I think gets at a lot of sort of quality of life as well as physical function assessments as part of clinical care.
Is that a validated instrument?
It's called the CARE GA. It's pretty quick. It's 42 questions. Patients can finish it usually in less than 10 minutes. So they just fill it out while they're sitting in the waiting area. And that helps me to understand sort of overall physical function and globally get a look at sort of their multimorbidity and the burden of sort of medical comorbidity on their life, nutrition, all these other things. But from a urinary standpoint, honestly, I use IPSS and sort of the basics routinely. I do think that this is actually something that a lot of us are involved with IBCG. We're working on now on looking at developing sort of a better parsimonious but also more relevant PRO that could be something we could all integrate into clinical practice routinely. That would not be a huge lift. I think the survey sort of fatigue gets to be a lot for patients. So it's got to be kind of quick and efficient, but also all the questions have to be relevant to these patients. So we're in the process of developing something like that right now.
Yeah, I totally agree. I mean, I think FACT and EORTC, those are kind of some of the best that we have, but we need something that's more tailored for intravesical therapy. So that'll be exciting. So a question for either of you, as patients are going down these more complex bladder-sparing pathways, receiving multiple types of treatment, sometimes they'll get kind of end-stage bladder type symptoms where maybe they would like to keep their bladder, but they're having a smaller capacity or dystrophic scars or calcifications. Are you doing any therapies for those patients? Botox, resecting the scar, things like that?
Yes. Not often. I think obviously with Botox, we want to make sure they don't have any active bladder cancer. But if they've had a disease-free survival that's 6-9 months and their cysto looks good, cytology is negative, and they're having overactive bladder symptoms that are refractory to beta-3s or whatever else our voiding dysfunction colleagues have tried, I have seen them use Botox. It's not really a common scenario. Most of these patients are recurring. That's maybe part and parcel to why they're having the symptoms to begin with, and they're heading towards the cystectomy. But occasionally, yes.
How about you, Sarah?
Yeah, I definitely, if someone's in the face of really bad lower tract symptoms, is still desires bladder preservation, I'll work with them and try, as long as the disease is truly gone. We make sure the disease is gone first, because a lot of times that's actually just a harbinger of bad cancer that's come back. But I would say that if we're trying to keep the bladders, we'll try Botox occasionally. Again, it's not something I've done a lot of, but I do have, we have done it. Resecting the scar, I think, is a tricky one. I do find that a lot of times you resect the scar and you end up with this almost like ulcerated bladder, kind of like an interstitial cystitis type picture with an non-healing ulcerated bladder that actually is more irritated. And also times I feel like you end up seeing a lot of recurrent UTIs in these patients. The bladders have a lot of sort of defunctionalized tissue that I think can become colonized. So I think it becomes really tricky. I have, this is probably my sort of bias because I have a research interest in it, but I will actually, for people who have no disease and just a really angry lower tract, I've had benefit with some lifestyle-based changes. I've seen benefit with lifestyle-based changes. So we work with our integrative oncology team. So nutritional modification, there's some interesting work around plant-based diets and sort of just changing what people are eating. And I've seen some patients who have really noted some benefit there. There's no good data to support this whatsoever. So this is completely like something we do in addition to all of the other work. And then acupuncture. We ran an acupuncture trial in patients who were getting BCG in the clinic and noticed that patients with in-clinic acupuncture had an actual statistically significant improvement using validated PRO-based data in their bladder symptoms over the 6 weeks of BCG. In patients who have really devitalized bladders, I have had some patients who have had some benefit with acupuncture out of clinic. Again, not high level data, but just something that works for some people and not others. So I that's the data that actually led to like the P10's approval. It was an acupuncture-based sort of physiology.
I love that concept and idea, and I think we're going to be doing more advanced bladder sparing over time. We're going to be using these treatments more over time. So we kind of, for better or worse, have to learn like this IC type physiology and how to help manage it.
Yeah. And I do have a partner who's really exceptional in terms of how she manages her IC patient population. And so I've had her see a couple of my patients, and she'll do different installations and steroid therapy. But at that point, I think a lot of those patients are pretty uncomfortable, and a lot of them become more comfortable with the idea of cystectomy.
Yeah. And the other thing we have to learn is all these new therapeutics that are coming out, how do they impact the bladder in the long term? Are they a little bit different? And we're going to understand that more as we use them in the real world. So we're getting to the end. Some rapid fire questions for you guys for some complex scenarios. I've been seeing an uptake of young patients with bladder cancer. And I think that's a concerning trend that we've seen at a couple patients in their 30s. And, let's say they have high-grade disease. Do you have different considerations when you're thinking about BCG or treatments in those patients?
Yeah, so I have seen them too, and have done a few neobladders in people in their early 30s for muscle-invasive bladder cancer. I don't know why we're seeing this increase. I don't know if it is an increase. I just don't have a sense for the denominator. Maybe it's been this way for a while, and it's just for whatever reason it's becoming more prevalent in my practice. I don't know. But for muscle-invasive bladder cancer patients, I tend to just stick to what we do, which is neoadjuvant cisplatin-based chemotherapy, although that standard might be changing soon. And then, orthotopic diversion. For high-grade T1 patients, those patients I'm leaning a little bit more towards cystectomy as well, just given the especially if they have high-grade features or, T1 or re-resection, I might lean more towards a cystectomy more so than I would in a 75-year-old that we discussed initially. For high-grade TA that we've completely resected, just garden variety, routine grounder, I would just do BCG. I probably wouldn't be offering anything more than that.
Yeah. I had a patient recently very interested in fertility, and he was asking, do we worry about BCG in that context? I didn't have a great evidence-based answer for him, but I did have him see our fertility specialist, just a bank, just in case something happened. Have you seen that be an issue?
Yeah, I'm not aware of great high-level evidence to sort of guide us at all in answering that question. I think it's a really smart question the patient asked. I agree with thinking about early banking. I think the only other point, because I feel like I've seen a lot of young people recently, is I'm definitely getting genetic testing in all of them, trying to understand if we can figure out where this might be. But it's interesting because we are seeing also an increase in colorectal cancer in younger patients and lung cancer as well right now. So the whys, I think we need to figure out from sort of an epi perspective, but definitely those are the people who I do think about an early cystectomy with orthotopic diversion in patients who are very high risk. But a lot of those patients are also really motivated to keep their bladder. And I think these are the tricky ones, right? Maybe it's a patient with upper tract disease who now has seeding of the lower tract, and you've done the nephew and you're trying to keep their bladder in, and they keep having high-grade TAs pop up. And those are the people who keep me up at night. I worry about them a lot.
Yep. All right, next scenario. This is kind of a puzzle, and I think a lot of it's provider preference, but let's say someone comes in with T1 ureteral disease and T1 disease in the bladder. So you kind of feel like they need an FU, but they also need intravesical therapy. How are you sequencing that?
I generally get the bladder clear first and then attack the upper tract disease. Very similar to, I think, what Sarah mentioned earlier. Is a patient that is distal ureteral T1 disease and they want a cystectomy, then I might take care of it all at the same time. Just do distal ureterectomy, cystectomy. But if they desire bladder and kidney preservation, then I'd get the bladder clear and then reassess, and then hopefully have ablated most of the upper tract tumor to the extent possible, and then attack the upper tract disease. I don't know if there's a right way of doing this. Obviously, the ureteral disease is more significant in terms of the threat to the patient. The ureter is just so much thinner, smaller. It just seems like metastatic disease is just so much easier through the ureter. But an early stage tumor like this, where the CT is pretty reassuring, and I felt like I've ablated most of it endoscopically, I think I would re-resect the bladder, give intravesical therapy, reassess, and then attack the upper tract disease.
Yeah, I've gone back and forth on it, and I think it's maybe case by case, depending on the volume of disease in either system. But it feels tough just to attack one area, but leave the rest for a little bit later.
I've landed the other way, which is take care of the upper tract first because I think of the oncologic threat of the upper tract, but also I worry that it's just continually seeding the bladder.
Right.
So I'll, clear the bladder, but then get that patient to nephew and then intravesical therapy. The tricky part, of course, is just how timing and how oftentimes we're booking out, several weeks to months. So sometimes you're like, listen, you're on the schedule for your nephew, but I have 8 weeks, so we're going to get you through your intravesical therapy at this point, and then we'll do that. It's sometimes your hands are forced, but I do worry about the continued seeding from the upper tract.
Yeah, and the only reason why I attack it that way, though, I just say that is because many of these patients, after their induction, they're T1 in the bladder again, or they have recurrent disease. So now it's a different conversation. Now it's like, okay, now while we're taking out your kidney, we're also going to do the bladder too. You know? And so like you said, you have
sort of a litmus test to see what's the natural history.
What is
here?
the bladder disease really? Because we know what can take out the kidney, and like you said, there's a latency period between when you can actually do the patient and when the patient has been diagnosed, and so really not delaying that much, probably 4 to 6 weeks. And I think kind of knowing that you're going to be doing the bladder at the same time, I think is an important piece of data that you want before doing the kidney. But that's a very difficult situation.
Yeah. It's interesting though. I feel like you're talking about the more disease in younger patients. I feel like I'm seeing so much more upper tract disease. And I know that there's some thinking that a lot of that may be related to the heavily treated lower tracts, and we're just starting to see the disease sort of progress in the upper tracts. But it's becoming a conversation I have to have more often than not, where it's like, here we have two problems. Here's how we're going to tackle one. Here's how we're going to tackle the other. But it's not easy. And it's, as you both said, it's case by case.
Absolutely. So we've focused mostly on high-grade, high-risk disease. You've been a champion for de-escalating treatment in kind of low-grade, intermediate risk cancer. Do you have any big take-home points you want to make about that context?
Yeah, I think, that's a totally different conversation. So intermediate risk disease, recurrent, low volume, low grade, non-invasive. We were talking about lethal disease previously. That intermediate risk disease is not lethal. And this is definitely not for patients who have small volume, high grade TA. That's a different beast. But for people who just have the low grade superficial recurrences, I think that being really thoughtful about how much you put those patients and their bladders through is actually important, because like we've just talked about, there is serious toxicity to a lot of the intravesical therapies we're talking about, and giving people, for example, multiple rounds of intravesical chemotherapy puts them at risk for a devitalized bladder that ultimately is going to lead this patient who never, from a cancer perspective, is going to need a cystectomy to potentially have to consider a cystectomy because of functional consequences. So I talk to patients long and hard about what we're going to do. I'm excited to see the PIVOT-06 data when we get there. We're enrolling on that right now. I think thinking about ablative therapies in the lower tract are going to be really interesting for low grade disease. But I do talk to patients about office biopsies and fulguration and keeping them out of the OR and keeping them away from general anesthesia, especially our older patients. I've not been a champion of surveillance myself as of yet, but I've had some patients who have kind of forced me to allow to work with them and sort of follow the Italian data on that. And I think that for truly low volume, I don't quite get to the 1 centimeter mark, which was what that cohort allowed. But for tiny, couple millimeter low-grade TAs, definitely think about surveillance. And sometimes, to your point, Mark, like watching what happens to the disease is actually important, because I think that sometimes that disease, it's going to actually just stay a couple millimeters, but then you do have those patients who all of a sudden will crop up disease in a lot of other places. And then I think about the induction chemotherapy and walking them down that path. But I think that this is not a hammer and nail situation anymore. And I think we can be as nuanced in our management of intermediate risk disease as we are in high risk disease. We have more options. We also can sort of take a pause. That's not cancer that's going to kill anybody.
Do you have a go-to first intravesical therapy that you'd use in that situation?
I use the gemcitabine largely because, it's less expensive and it's better tolerated, I think, than the mitomycin C. And I hold off on the mitomycin for those patients who have multiple high volume, low grade superficial recurrences. And I do think it can be helpful, but I do also, you see that some of those patients are the ones who you end up really hurting their bladder function. So thoughtful about sort of pulling the trigger on that.
Mark, do you have any other thoughts?
Yeah, I agree with Sarah. I don't have a lot of people in my practice who are on observation for low-grade appearing recurrences. I have about 10 though. And I do recommend it for some people. And Mark Holloway's been talking about this for decades. And I can just say from anecdotal experience that I have a number of people whose low-grade appearing bladder tumors, low-grade history, negative cytology, upper tracts are clean. You put them on surveillance, and every 6 months, their tumors are unchanged, and they're unchanged for years. And I've even talked to a couple of them about chemoablation. I said, hey, on the horizon, is this chemoablative drug? And many of them have said, no, thanks, we're okay. Just like they have not really... They have not seen a change in their tumor, and they're actually quite happy with surveillance. I think this is something that we need to consider for certain patients, especially those who are older and comorbid.
Yeah. Are you using that new mitomycin gel recently FDA approved?
Yeah, I haven't used it yet. Interested. I think in the right patient, it's going to be very important. I think that the possibility of using ablative therapy and keeping people out of the operating room is incredibly enticing and really important. So excited for sort of all of the different ablative therapies that are getting evaluated in this space. I think the SAR-210 is also going to be interesting given sort of more of a biologically directed mechanism. I think that's interesting with the FGFR inhibitor. I think that it makes a lot of sense to be thinking about using that kind of mechanism in this disease space. The one thing I will just say though is I'm a big proponent, although I think I'm okay. And the data says that we think we are generally pretty good at recognizing low-grade tumors. Every once in a while, you have a patient who progresses to a higher grade. So I think that actually doing the office biopsies can be really helpful just to make sure you're talking about what you think you're talking about.
Yeah, that's a good point. There's some studies that say we have 80 to 90% accuracy, but that's 10 to 20% patients that we don't get right.
And every once in a while, you'll have one of those intermediate risk patients who will start to develop some focal high grade tumor. And then I'm thinking of one lady in my practice who I'm taking to the OR this week for that, who she's been doing relatively well, but on her last office biopsy, there's some focal high grade. So we're actually going to go and clear her completely in the operating room just to make sure we're not missing anything.
Great discussion. Mark, any final thoughts?
No, I appreciate this opportunity to be here with you and Sarah today. Really exciting time for our patients. There's a lot of work to do, I think we need to see in the BCG unresponsive space, I think we need to see a couple things. I think we need to see prospective validation of gemdosi. I think we need to start to see some comparative data as well. Natafergine, nogapendican, pembro, or some combination concepts therein. Credo, TAR-200 are on the horizon. We don't have any clue which drug to use in whom and when, right? So I think we need to start to do that work. I think the cooperative group mechanism is probably the best way to do that work. And so I'm excited to see that. I think in the kind of BCG exposed space, love all the concepts that are coming, gem credo, detalimogene, all of those concepts that are being done in that space, GAIN, I think are important. The chemoablation setting, I am interested in using UGN 101. I was an Optima 2 investigator, or sorry, 102. I said 101. UGN 102. I was an Optima 2 investigator, and I did see some good complete responses. I think whether we should sell the farm for low-grade disease, I think is a different question. But I do think that drug has activity, and knowing when to use it, I think will be an important question for KOLs like yourselves to sort out for the rest of us down the road. But I think it's a very exciting time to be in this space.
Awesome. Really well said. Awesome having you guys here today. It was a great discussion. Thank you.
Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.